There we
Welcome,
go.
welcome everyone. Thanks so much for joining us today, and we will be recording this for future people who would like to see it in the future. I'm so excited that we have Rabbi Dr. Rena Arshinoff today. I've had the pleasure of connecting with Rabbi Rena on a variety of different factors, and she's done an interview with me on spiritual care, and that'll be available in upcoming weeks. So now Rabbi Rena's done almost everything you can in the healthcare field. So she was ordained in 2008, but she trained in hospital chaplaincy and is a board certified chaplain with the Canadian Association for Spiritual Care. And she holds a certificate in bereavement education and a certificate in grief and trauma counseling. But before rabbinical training, she was a registered nurse in Montreal, and she holds a BSc from Concordia, and she did a master's in health science degree in epidemiology here at University of Toronto, and she worked for 20 years in clinical research, starting in AIDS-related research. She is a board member of Neshama, an association of Jewish chaplains, and she holds a PhD in palliative care from Lancaster University in England. And that's what we're going to hear her PhD research today. She also volunteers with bereaved families in Ontario in the Children's Program and Infant Loss Program as a group facilitator and professional advisor. She's an adjunct lecturer at the Faculty of Family and Community Medicine here at the University of Toronto, and she teaches in the Bereavement Education Certificate Program here at U of T. And Rabbi Rena often points out that the World Health Organization's definition of health includes a spiritual component to health. So thank you so much, Rabbi Rena. We're looking forward to hearing from you today.
Thank you, Esme. Thank you. And thank you, everybody, for being here. I'm very honored to have the privilege of presenting. This is my doctoral research. So sometimes people assume that I did the PhD in spiritual care, but in fact, it's palliative care. And I work in palliative care as well here at Baycrest. So very important overlap of both of them. So the title of my presentation is very long: Experiences of Mutuality in the Spousal Relationship in Advanced Parkinson's Disease, from the perspective of the caregiving partner, the application of Lifeworld Existentials to uncovering the impact of advanced illness. And I'm going to go through each piece of this. So the structure of my presentation, you see, is we'll look at the background to the study and the methodology and the methods results. And I do have some actual quotes from some of my participants. It was very difficult to choose which quotes I can bring given the not that long period of time. But we will take a look at some that are very moving. And application of the findings to providing palliative and holistic care, and conclusion, and then we'll have some time for questions. So we'll start with Parkinson's disease, which we tend to call PD. So PD is a progressive, degenerative, neurological condition that often can last for many, many years. It's characterized by slow movements known as bradykinesia. Some people have a tremor, not everybody, but everyone has rigidity and postural instability, which means challenges to standing. Some people will have these involuntary, jerky movements, and you may see people kind of moving like this, known as dyskinesias. That often occurs as the disease progresses. And sometimes, even when the disease isn't advanced, as people's medication wears off, they will have some dyskinesias. But there are countless physical symptoms that come with Parkinson's. Huge list of symptoms. There are often emotional dysfunctions, cognitive changes, sleep problems. People tend to be prone to falls. So it's an illness, as one husband said to me, PD affects everything. And that was just like, he couldn't have said it better. So as disease progresses, many people, not all, will have psychiatric conditions and neuropathic pain. But often people say that they have struggles dealing with the lack of predictability each day, with the drooling, the toileting issues, difficulty walking, standing. Often people, and this is part of the condition, have apathy. If they're asked, do you want to go out this afternoon? No. The typical answer is no. People tend to feel isolated. Sexual challenges are huge. And people have this altered sense of body image of how they look and how people view them. So what happens physiologically is that PD patients have decreased dopamine in their brain, which is a neurotransmitter that we all have. And it's how our hand knows to move the way we want it to, because a message is coming from our brain to our hand through dopamine. Whoops. And I can't quite see. People with PD have what is known as an on-off phenomenon, that they take their medication and they can move pretty well, and then all of a sudden they freeze. And it may or may not be related to when the medication has worn off. But everyone with Parkinson's knows that on-off phenomenon. And people will say, oh, I had this feeling when I was off, or I'm pretty good when I'm on. And it's a well-known phenomenon. So for PD, the Hoenn and Yar Scale is used around the world. So Hoenn and Yar were two physicians who developed the scale to describe the 5 stages of Parkinson's. And you can see stage 1, stage 2 are sort of minimal involvement. The disease by stage 2 is progressing a bit. By stage 3, there's bilateral disease, so people have difficulty with both sides of their body, but they're still pretty physically independent. Stage 4 is severely disabling disease, but people are still able to walk or to stand if they're assisted. And stage 5 is confinement to bed or a wheelchair, total care, really. So palliative care in Parkinson's disease, as I just mentioned, there are many debilitating symptoms as the illness progresses. And what happens is that usually the person with PD is dependent on others. In most cases, it's the spouse who's the primary caregiver. So research has been conducted with PD spouses who are the caregivers to look at burden of care. And there's been some research on quality of life, but there has been very little research on mutuality, especially in advanced Parkinson's. So PD, as we know, is chronic and degenerative. It has a long trajectory with all these physical, cognitive, and emotional changes. So palliative care principles are very relevant in Parkinson's. People tend to think that palliative care is more for cancer or maybe heart failure, but in fact, palliative care, according to the World Health definition, includes looking at pain, psychological distress, spiritual distress, and social needs. It's applicable at any time throughout an illness trajectory, according to whatever the patient needs. And in palliative care, we provide support not only to the patient, but to family and or the patient's care circle. And we help them with their own bereavement. So very relevant to Parkinson's. Medical visits, and I used to work in a Parkinson's clinic, tend to focus on physical symptoms. And there's less attention given to the psychosocial effects, such as relational satisfaction, emotional and spiritual well-being of the patient and the family. So what is mutuality? Well, there are a number of different definitions, but basically it is the quality of a relationship and the degree of reciprocity in that relationship. Tanji, who has done quite a bit of research, says it's the quality of interaction in that relationship. It involves the sharing of characteristics, goals, and attitudes, and in marriage with increasing commitment. And for those of us who are married or in like a common law or a meaningful relationship with someone else, we know that a relationship shifts from the concept of individuals to the concept of a couple. And couple identity strongly influences the degree of satisfaction in a married couple. So mutuality is at the core here, and it involves intimacy, gratification, hope, and meaning that is shared by the two people. And it's a dynamic process. So we see how these two arrows are working toward each other. On the left, each partner sees him or herself in relation to the other with their shared goals. And it's dynamic with give and take. We know that. And people in a couple relationships share activities, memories, emotional closeness, confiding in one another, caring about each other. And on the other side, each person validates the other and participate in shared goals, and there are close affective relations. So caregiving is a component of close relationships, but it's accompanied by stressors of relationship quality, and illness, as we know, brings up many emotions. And in chronic illness, over time, couple identity can change if the focus of that relationship is about the caregiving. So in caregiving, the shared humanness of mutuality can result in asymmetry when one partner is dependent on the other. And the one who he or she is dependent on is now a caregiver. And this is because of the physical, cognitive, and emotional changes in the partner who's ill. So I had seen in my work in the clinic that often couples were coming in and it was almost like a love-hate relationship. And I was wondering what's going on here. So I did a look in the literature, and I found that there's very limited research on mutuality in PD. Each partner is affected in their own way in chronic illness. But in Parkinson's, there's really very, very minimal research. Only a little bit has been done in the early stages of illness when things are a bit easier still. Most of the research I found was quantitative, and people participating were asked to complete validated questionnaires. There was less qualitative research, and I found nothing in advanced disease. So research is needed on the lived experiences of changes in relationships and expressions of feelings and mutuality in advanced stages of PD. I wanted to hear what was it people were feeling rather than having them check off like number 3 or number 2 on a Likert scale. So my research question was, what is the lived experience of mutuality and the impact of advanced PD on the marital or common law relationship from the perspective of the caregiving partner? So you're probably thinking, why caregiving partners and not both? Well, many people with advanced Parkinson's could not engage in an interview. They have typically decreased ability to speak and usually inability to concentrate for that length of time because of cognitive changes. But more importantly, I wanted to give voice to the caregiving spouse who rarely receives attention during clinic appointments. So the idea of we-ness in couple identity is often seen differently by each partner living with chronic illness. And I didn't want one to be influenced by the other. And Hempel writes very wisely that research with caregivers is lacking and it's really necessary. So what was my methodology? I used phenomenology, which is the study of the life world as the world of lived experience, the world as it is experienced in the moment. What is it like for you today? What is it like now? What is it like living with a spouse with advanced Parkinson's? Rather than, as Van Manen says, how people think or theorize about how the world should be or how they would like it to be. What is it truly like right now? And this way, we try to understand the essence of a phenomenon, and that helps us to have a deeper understanding of what that person is experiencing. So there are two types of phenomenology: descriptive and interpretive. So descriptive will look at describing the phenomenon. Interpretive seeks to, as the name implies, interpret what it truly means. And it's also known as hermeneutic. So I chose to do a hermeneutic, phenomenologic, qualitative study using Van Manen's methodology. And Van Manen has a very interesting methodology, part of which I will show you here. He says that there are what he calls existentials, very broad themes that make up the life world of each person. And he also has a whole methodology for writing, which we won't even touch due to lack of time. So 4 existentials: spatiality, which is about lived space, which is about one's personal safety and how secure we feel in our personal world. Temporality, lived time, our personal perception of time, looking at our past, our present, and our future. Corporeality, our sense of lived body, how we see ourselves and how others see us. And relationality, lived other, our relations with others. And this, of course, was what I was very interested in. So I'm going to show you some results for each particular existential in a little while. So the methods, after I received research ethics approval, the study was conducted with participants in a Parkinson's clinic designed for people with advanced illness. I had 12 caregiving spouses, 7 wives and 5 husbands, each of whom took care of their spouse with advanced illness. And everyone participated in a single interview, which was done in person. And they provided informed consent. Interviews were recorded and transcribed. So I'll show you my interview questions. They're very, very broad, and I had probes for each one. So you've told me that your spouse has had Parkinson's for, and they would tell me how many years. Could you tell me about your relationship with him or her since the diagnosis? Please compare your relationship now to how it was before the Parkinson's became advanced. What kinds of activities do you do together? How do you and your spouse experience intimacy now? How would you describe your love for your spouse at this time? And how has being a caregiver changed? And it seems like there are only 6 questions, but I had reams and reams of data. So each question had probes that were all approved. And I did ask a question about spirituality only if time permitted. So inclusion criteria were a caregiving spouse or common law partner to an individual with stage 4 or 5 Parkinson's, as I showed you in the Hoenn and Yar Scale, and that had to be designated by a physician. Both partners had to be residing together in their home. the participant needed to be able to answer questions in English and to participate in a 1-hour interview. And the exclusion criteria were exactly the mirror image. Van Manen does not indicate a sample size that has to be done. He says it's more important to understand the experience of the phenomenon, and when you feel that you have enough information, then you can stop interviewing. So I approached 15 potential participants, 13 of whom accepted right away, 2 declined. One of the participants potential participants who had accepted changed her mind prior to the interview date. So the final number of participants who completed the study was 12, which for a qualitative study is quite large. And 11 of the 12 interviews were conducted at their home. One wanted to come to the hospital. So the results were, as I said, 7 caregiving wives, 5 caregiving husbands. The average age was 75, and they ranged in age from 70 to 86. They were all married, ranging from 26 to 65 years. Some of them were in a second marriage. All the participants were retired, and the length of PD illness of their spouse ranged from 2 to 32 years. And the reason one person had a diagnosis length of 12 years was that for many, many years, they thought he had something else. And it had been only 2 years since it was finally diagnosed as Parkinson's. So I'll show you what some of the findings were according to the existentials. So for spatiality, which was lived space, there were 3 broad areas. Home is no longer the sanctuary it was. Where can we go? And feeling trapped at home. So home is no longer the sanctuary it once was. This caregiving wife said, sometimes I'm waking him up. Sometimes I go towards where he is in bed and I can't find him. He's on the floor. Sometimes it takes me 20 minutes to half an hour to get him off the floor. I try to get him to hold on to the pole and to pull himself. I don't want to leave him too long because that means he will pee in the area he is in. Home was no longer a sanctuary for her. Where can we go? This person said, I sit and dream about wouldn't it be nice to go here or there. We had planned our retirement. We were going back to Hawaii, back to New Orleans. I wanted to do some other countries. And another wife said, we very seldom have friends in. We're in a Bible study group together. They meet here in the winter, which makes it easier for us. I will take him down and we play bridge in the party room. He sits in the TV lounge and reads. And she really stressed how she hates feeling like a babysitter. Feeling trapped at home. I miss my friends. I've often said to X, her husband, I wish I could go into the city and take a bit of time and see some old friends or go back to some old familiar parts of the city I like. But I guess I'm dreaming. I'm stuck with what I have. When he could drive a car, periodically we would take a day and go into the city, pack a lunch, and go to different parts of the city. Someone else said, I'm in prison here without bars. And another wife said, if I'm alone with him, I don't go on the balcony. I don't want to be pushed off the balcony. I go out on the balcony either when he is asleep or when somebody is there. So now temporality themes, live time. Before and after the PD became advanced, acceptance over time does not occur for everyone. The daily experience, negative self-regard over time, and most time is spent together now. So in a progressive illness, time tends to be thought of as how life was before and after the diagnosis, how it was before and after the illness became advanced, and their daily life. So before and after, we do not resemble ourselves to how we used to live, how we used to be until now. Now we look like a couple of deadbeats that are always home, and we are like a couple of recluses. But that's not who we are. But this illness has ground us to a halt. This has ruined our lives, my life, his life. Acceptance over time doesn't happen for everybody. This lady says, I don't want to spend the rest of my life doing what I'm doing. I just can't take it anymore. And another caregiving wife said, I made the decision there is no use my trying to change him. I still try from time to time, but in this partnership, the only person that can be changed is me. Daily experience, this caregiving husband said, every morning I spend 2 hours sitting side by side. I just sit. Sometimes I fall asleep. Sometimes she falls asleep. And negative self-regard over time. People are very hard on themselves. I'm more short-tempered. I'm more irritable. I was never big on patience, but I have none at all. I have no patience. I'm irritable. I'm grouchy and I'm snarky. And this caregiving husband said, sometimes I feel dissatisfied, but I try again to be on the right way and say it's wrong. I should be patient. And most times spent together now, this wife said, I'm with him 24 hours a day. I'm old now. I don't know when I will get sick. And then we come to corporeality themes, lived body. And I needed to get my head around this because it wasn't about the body of the spouse with Parkinson's. It was about the caregiver. And so the two themes that came up here were awareness of one's own physical limitations and sensory and sensual responses that affected their mutuality. So this caregiving wife said, my body is falling apart. I'm also aging. So I think the stress is having an impact. I'm starting to see what it does to my body. And this husband said, it just wears you down after a while. I am not the healthiest person in the world. I will be cancer-free in October. And then I have COPD and arthritis. And then I looked at what they told me. There was a lot of data about the senses. So for hearing, I heard this from many people. It is more and more silent time. We have a lot of quiet time. The loss of his partnership in the daily conversations. We do have conversations, but often they are so pedestrian. Sight, this husband said, seeing her when she's in a mood where she is slow. I don't want to use the word retarded, but I can't believe it that this is happening to her because she was a very, very intelligent woman. Smell, he pees on the hall carpet at 6 o'clock in the morning. I have to clean up. There are stains, there is smell. Do you know how many times I have to clean it? Sometimes 4 or 5 times to get the smell away. Touch. Touch was usually with reference to caregiving and not intimate touch. This husband said, sometimes 5 times a night, I must take her out of bed and she is losing strength completely, like a potato bag. And taste was tied to eating. You are continually having to move his food over to the appropriate side or cut it up. And people often said they just didn't have any enjoyable meals together anymore. And relationality themes, of course, given my subject matter, there were more themes for relationality. The challenge of finding enjoyment in each other. Activities shared together now are very dull. The PD partner has become like a child. The impact of PD on the marital relationship. The wish to recreate the past. Relationality with God and love. So the challenge of finding enjoyment in each other, no, not very much, said this wife. We cannot have a conversation when we walk because he has to concentrate on actually walking. Sometimes we went to concerts, to theaters. The last time we went, we had to leave because he was just in a panic. And someone else said, his sense of humor is pretty well shot in terms of laughing about something. Our fun together was kayaking, it was bicycling, it was philosophical, it was political. Those were really fun times. And this lady said, fun is a bit of a stretch. Shared activities now are very dull. This caregiving wife said, no, nothing much really. It would be nice if he could, for example, play crokinole. The PD partner has become like a child. This wife said, he's like a toddler. But with a toddler, you say, go in the playpen. You can't say that, and he forgets anyway. The wish to recreate the past. Partners shared in almost all cases their pride in their spouse and how this really strongly affected mutuality. This husband said she was an avid writer at one point. Yes, she has been published. She did win a prize. She was a runner-up in the Stephen Leacock short stories. But on the other hand, this caregiving wife said, I tried to show him how to do things. I have a husband, but there was nobody here. The impact of PD on the relationship. I feel the partner, the intellectual, mental partner, is not there. And this husband said, chief cook and bottle washer, I do everything. This other husband said, sometimes I kiss, yes, just like you would kiss your baby. You understand it is not a love kiss. And 11 of the 12 participants talked about the importance of their faith and their spirituality. And this lady said, we are Muslims, so I have to do my study, Holy Quran, and pray most of the time. Muslim peace, yes, a very strong faith. I believe if your husband is happy and when he is sick and needs you, if you take care of him, God will send you to heaven. And finally, the theme of love. When people were asked to, how would you express your feeling of love for your partner? I have several interesting answers here. Oh, that is a big question, because it is a love very pinched with sadness and pity. And I can say whenever I feel sorry for myself, I kind of say, if this is so hard for me, think about how much harder it is for him. And so it kind of recalibrates my feelings for him. This other caregiving wife said, I had a hard time buying a birthday card or Christmas card because half the things in the cards don't relate to how I feel. And someone else said, well, I get nothing sexually from him. Kiss, maybe. This husband said, it's a different kind of love. It's not love to make love. It's love for compassion, humanitarian love. I don't know. I don't have the right words. This other husband said, she is my life. And finally, this wife said these very beautiful words. I would say the word is enduring. Love is wanting the best for the other person. It's not about what you can get from it. It's about what you are together. So taking these statements and all the other data I had to write a discussion chapter, and what were my insights? So I'm going to share those with you. Loss of identity as a couple, ambiguous loss, finding meaning, and gender differences. So loss of identity as a couple, and throughout this whole project, I kept thinking of what that husband had said, that PD affects everything. Parkinson's is a couple disease. This is what Hodgson wrote. It's a chronic impact versus an acute illness that has a quick decline and death. With chronic illness, this impact can last for years. Sadness is very common when there are changes in everyday life that affect the dyad, the couple who they are, especially when there are cognitive changes and they don't have that same relationship. Some caregivers see their role as secondary, especially when visits to the doctor take place. They often see their role as less important and they feel invisible. Many feel guilty about how they speak to their partner because of their frustration. Even when mutuality was high in some of these couples, their couple identity suffered. And most said they have few activities that they enjoy together that they used to be able to do. So some participants told me that they feel an obligation, that they have to take care of their ill partner because they're obligated, but they experience lack of meaningful communication. um, with the loss of an equal partnership. And we heard that in some of the quotations. People experience, the participants said they experience a change in their own sense of who they are, their sense of self. They have a lot with a loss of intimacy. Some people feel that they've been abandoned, that their partner doesn't care about them anymore in an intimate way. There's social isolation because they just can't socialize the same way with friends. People have to take on new roles that they don't necessarily want to. Like that husband said, chief cook and bottle washer, I do everything. And caregiving takes a physical toll. These are not young people. People have watched the fading of their partnership and their joint mutuality slip away. And that contributes to a decline in mutuality for many people. And with each symptom that the ill partner has, it's like another snatching away of the person. So there are lots of changes and disappointments, especially when the speech is diminished. There's lack of meaningful communication that often results in loneliness for the caregiver. Not hearing their partner's voice is very painful. And one of the husbands said that has been harder than losing their sex life. A loss of connection and couple characteristics with severe cognitive changes really makes that lack of equality in their relationship so real. It becomes unbalanced with the lack of intimacy, the social isolation, the new roles that people don't want to take on, and they question, are we still a couple? Some people say they feel like it's a nurse-patient relationship. So what happens ultimately is a lost lifestyle. We all know that we hope and dream that in our retirement we'll do things that we either didn't have the time or the money for in our younger working years, and now that gets lost. They experience loss of shared interests and activities. They lose their socializing. What hope is there for the future? And as I mentioned, this nurse-patient relationship. For some, they feel obligated to take care of their spouse, but most said that they wanted to be with their spouse, despite the loss of physical expression of love, not hearing "I love you" or having some intimate relationship. And caregivers need to be heard by the physician and the medical team. I heard that a lot. And one lady said, caregivers are taken for granted by physicians. So ambiguous loss. Ambiguous loss is a concept that was developed by Pauline Boss. There are two categories. Sometimes there is the case of a person disappearing, there's no body, such as a soldier who's lost in action. But the second category is that the person is there, but not there. A physical presence with a psychological absence. And Doka takes this a bit further and says the person is there, but the essence of who that person used to be is gone. And so many are proud of their spouse's accomplishments. And as we heard from that husband who talked about his wife's writing, but their essence is absent now. And a lot of people who are caregiving feel resentment, even if they do have some help. Some said they still enjoy spending time together, but they don't have the same excitement. They feel differently about their partner, and that results in that ambiguous loss. For some people, a love-hate relationship arises. Each day can be so unpredictable. Some are good, but there's no guarantee that tomorrow will be good. And there's a lack of patience, confusion, fear of judgment. People are on an emotional roller coaster as they're caregiving. Some people experience chronic sorrow. And chronic sorrow is something that Caroline Lindgren has done a lot of work in. And she says it's a continuous grief that occurs in a cyclical pattern of resurgent feelings of sorrow, interspersed with periods of calmer emotion, a real emotional roller coaster. And with each symptom, it seems that that person who a caregiver once knew is gone even more, snatching away. It's hard to watch a loved one suffer. And it's confusing when some days are better than others. You can never count on the next day being good. And mutuality is vulnerable when ambiguity takes over the relationship. The third is finding meaning. Very, very difficult for caregivers who are faced with daily challenges, with ambiguous loss, and the arduous task of finding meaning within all that confusion of their emotions. Finding what is fulfilling and creating opportunities to engage in meaningful activities is not easy, and they have to find and accept whatever the new normal is. And what the extent to how a caregiving spouse can do that can affect mutuality very seriously. And among my 12 participants, many expressed caring deeply for their spouse, but nobody spoke of any positive responses to caregiving. Viktor Frankl, who's done a lot of work in his Holocaust experience and then developed logotherapy, finding meaning, said that even in suffering, it's very difficult as a caregiver in advanced Parkinson's. Feeling the emotions of grief for a person who's still alive is very, very confusing. And what happens often is that other people don't understand that kind of grief, and they see this couple and they think everyone's doing okay, and the caregiver's grief is often disenfranchised. Some people said what helps them is that when they go to clinic appointments, they see other patients who have more advanced Parkinson's. So it gives them some sense of relief that their partner has less severe illness, but then they feel guilty about that. Finding hope and meaning is very highly individualized. In chronic illness, what is hope? Hope is not going to be for a cure, but maybe for a better day. And it's hard to find balance between times that are enjoyable together and finding time to be with others. And this creates this involves a lot of creativity. I found that optimism was present more in participants who felt that they had higher mutuality. And several people used this expression, I have to deal with the cards I was dealt. And acceptance does not imply finding meaning. Finding meaning did not come easily, if at all, for most people in my study. Some were aided by their feeling of enduring love that they felt toward their spouse, and some felt loyal because they felt they committed themselves at the time of marriage for better or for worse. But for many, mutuality was caught up in a cycle of illness, limitations, resentment, suffering, impatience, and this impatience with others who think they're doing well, but in fact they're not. And for some, there was a drastic decline in mutuality in their relationship. And then I looked at gender differences. And participation in health research historically has attracted more women than men. So I tried very hard to have an equal number of both. I didn't get quite to 6 and 6, but I thought 7 and 5 was pretty good. The literature suggests that men have an easier adaptation to being caregivers, and I found that in my research as well. The women tended to say that they must care for their spouse, while the husbands said they wanted to give back, and that may be because of all the years they were working and their wives were caregiving. So wives with low mutuality expressed increased strain versus wives with high mutuality, which makes sense. And they that was accompanied by risk of burnout and resentment. And in my study, both husbands and wives expressed sadness about the changes in their spouse and the decline in their mutuality. The wives expressed more resentment, the husbands expressed more sadness. Wives showed more disappointment about lifestyle changes, whereas the husbands were better able to accept that. And that may reflect societal view of wives versus husbands. 4 of the wives said emphatically they no longer enjoyed spending time with their husband. And all 5 caregiving husbands talked about wanting to be with their wife despite their health status. Wives spoke of all that they had to do, and few sat with their husband just sitting there as the male counterparts did. And all the husbands shared deep love for their wife and still feeling attracted to them. They didn't feel abandoned, but that was not true for caregiving wives. So wives tended to be less likely to seek or accept help, which was different for the husbands. Some of the husbands said that they had more breaks. They hired a cleaning lady more often compared to the wives, but all experienced profound sadness regardless of the level of mutuality they had. So my assumption when I began this study and I learned about these existentials was that all 4 existentials would be contributing equally. However, what I found was that was not true. I found that relationality contributed the most to mutuality, followed by spatiality, and then temporality, and finally corporeality. This is not drawn to scale, but this is my conclusion from my experience. They all contribute, and this was very interesting because in my reading, I had read an article about a study done on childlessness, and corporeality was the most contributing factor due to problems with infertility. So in terms of application of findings for providing holistic care, it's important to validate caregivers' feelings of grief and that they matter, and what brought meaning to their relationship before. How do we help them to find what's different now, and how can it be rediscovered? It's important for us to stress to caregivers that personal time is crucial for their own health, and that we need to validate that what they do in their caregiving makes a difference for their partner and for them as a couple, and that we need to help them to find strategies for having fun. For health professionals, we need to be aware of gender differences and how caregiving spouses see what society expects of them. They need to know from us that they need breaks. And how can we help their mutuality to be improved if that's what they desire? Some people may not want to have an improvement in mutuality. During the pandemic, we don't have day programs, but they're very helpful for respite care. The person with Parkinson's has stimulation for the day, and the caregiver has a break. And support groups are very helpful. We need to encourage caregivers to take part in these. But we need to provide opportunities for caregivers to be heard, and that's a lot of what I do, and for them to accept help in their home. And we need to remember that PD affects everything. There are many, many losses in advanced illness on all levels. The intensity and depth of despair and feelings of isolation amplify the losses in advanced PD. And family members become invisible, burnout is often overlooked by healthcare teams. And advanced PD involves mourning losses and changes in the marital relationship due to the illness. At the same time that caregivers are feeling deep care and love for their spouse, but it's complicated by the resentment that life is different now from what they imagined it was going to be. So in providing care to these couples, we need to remember that clinic visits pay little attention to relational satisfaction and well-being of the patient and family, and we need to change that. Paradoxically, the person who cares most for the patient often gets overlooked. Mutuality is complex, and it's influenced by many factors. Individuals with advanced Parkinson's don't live in a vacuum. The illness affects their family members, especially the caregiver. And the healthcare team must as a unit understand how PD affects the marital relationship for both the patient and the caregiving spouse, both of whom require recognition and acknowledgement in this debilitating couple disease. So in conclusion, the four existentials offered a holistic framework in understanding the phenomenon under study, which in this case was mutuality and advanced PD. The existentials contribute to exploring layers of meaning in the four unique contexts. A great deal of overlap exists among them, and it will differ for various illnesses. And this was especially relevant to Parkinson's disease, as it is for many other illnesses that has many dimensions. And the use of the existentials identifies core components of the unique challenges for individuals and families living with various illnesses. So they're relevant as a framework in clinical practice and in providing a palliative and holistic approach. Mutuality is at the core of the marital relationship, and it's susceptible in chronic illness to resentment, to lack of satisfaction, to feeling abandoned, to feeling unattractive by both partners in the dyad. Relationships may last for many years in an outpatient setting or even in a hospital setting when there is a chronic illness. And the World Health Organization reminds us that palliative care is about living and quality in living. And by understanding mutuality, we hope to provide a palliative holistic approach that recognizes that even though someone has advanced PD, they are living, and we hope to help find quality in living. So some references and questions.
Oh, so thank you very much. That was very profound and really deep, what you found. Personally, it sounds to me like there's a book there. So I'm conscious of the time that it's sort of 5 to 1, and I know that some people will need to go, but there's been a very vibrant discussion in the chat.
Oh.
And I'm just hoping that people will unmute, maybe start with, let's see, Ronnie had a shorter one. Ronnie, do you want to just share your question first, and then we'll go to...
yeah, I'm going to stop share screen. So stop. Okay.
Thank you very much for your studies. My question is, how did the parental status of couples, was that a factor, or did that influence, i.e., if couples, particularly mothers, have gone through parenthood and caregiving in that, and then become a caregiver for a spouse, a partner?
Yeah, it's a great
Thank
question.
you.
A great question. I had several people tell me, I spent my whole adult life, well, not whole adult, I spent many of my adult years taking care of my family. And in some cases, there are elderly relatives, like an elderly aunt or somebody else, a sibling, and now they're taking care of their ill husband. So absolutely. And husbands often said they wanted to give back because their wife had been home taking care of their children. And these are elderly people, so times are different. That came up a lot.
Thank you so much. Excellent study. Thank you.
Now, I don't know who the Acclaim Health, who that person is, but you had several comments. Do you want to just unmute and sort of ask or comment or ask? Sorry, I don't know if you know, but one of those labels says Acclaim Health. That's the person who wrote the last comment for thanking for a wonderful presentation.
Oh, how lovely.
Yes.
That's great.
Yeah, I don't know how to summarize what some of my thoughts were. I think maybe just looking in the chat, it's a question that comes up sort of with the men and the women. Why
Oh, yes. So you wrote it very articulately. Do you want me just to read it from the chat?
Yeah, sorry, I can't quite condense.
Okay. So her comment was, interestingly, husbands adapt better to the caregiving role and wives find it harder. I wonder if this is part of the reason that each gender chose to participate in the study. Women seek to find acknowledgement of their sacrifice and endorsement, and men seek to brag and share about how they're able and seek to encourage others. Therefore, I'm asking if women caregivers feel that they are coping, they don't participate because they're focused on caregiving and feel they don't need the support validation. And if men feel they are not coping well, they don't participate because they have nothing to share and do not feel that there is any help or validation to get from sharing. 3 question marks on that one. So
yeah, so there's a lot in that. You know, I did not really look into the research as to why women participate more than men do. But I just know from my reading in the literature that we know that women tend to express themselves more. The husbands in my study, just incredible people, were all very sad. All of them very sad about their wife's situation. And I think when I approached them about participating, they were, oh, you want to hear about me? And it was about them. It wasn't about their wife. It was about them. I'm not sure what it was that made all 5 husbands I approached say yes, which was different from the women, because there were 3 women who declined, one who had accepted initially and then declined. But you know, I think husbands have, from what they told me, they have had many more years of getting out of the house. They were going to work every day. They were coming home at the end of the evening, having enjoyable time with their wife and their children, and then going back to work again the next day. And so for them, being home and being a caregiver maybe was not as trying in terms of their time as it was for the wives. The wives resented all the time. They had spent all those years taking care of others and had hoped that retirement would be a time for them to have enjoyable years. And I wasn't able to share, you know, I gave another presentation that gave me 90 minutes and I was able to share more of the data. So I had to pick and choose here. But a lot of the women tended to just isolate themselves in their house because they didn't want to go out. They didn't want to run the risk of their husband having to go to the bathroom. Where are they going to find that? Or having a fall, or you know, oh, I better make sure, what's the time? I better make sure it's time for the medication now. They tended to be of the opinion it's better to just stay home.
So I'm aware you have some, it'd be worth reading the acknowledgements just because there's some people who have to leave. Of course, I'm aware we are only going to one, but if people want to stay after, the other piece is Susan put together an evaluation form that we would really value you filling out. It was popped in at 12:54 in the chat if you have a chance to do it. And Jane, if Rabbi Rena, if you're willing to stay a minute or two later, and Jane is reading a bunch of comments, and anybody else after Jane is welcome to comment too. But Jane, did you want to add comments or thoughts or a question?
Yeah, I just wanted to thank you for the presentation and your research. So I did put some, you know, information, more information that I pulled from some of the presentations that I've done for the Parkinson's Society, and talking about community assets, which, you know, Mosaic does a lot of social programs. And prior to COVID, we had actually a lot of Parkinson's clients come with their family member, which was kind of nice. We did, you know, the slower pole walking or walking groups and different social programs that connected people. So we did find that there was a lot of the family cares coming as well.
Right.
And Mosaic focuses on a person-centered care approach. So I was asked by the Parkinson's Canada, this was, I don't know, maybe 3 years ago, to do a presentation on community assets. Also compassionate communities. I don't know if you've done any sort of work on that, which is a holistic approach as well. So I just put some information. They weren't really questions. I just thought, you know.
Yeah, thank you for that.
Oh,
I think there's a way to print this, but I don't know how.
No, I will copy it for you, Rabbi Rena, and
Oh, thank you.
so that you'll have it at the end.
Thank you. I'd love to learn more about your work.
well, I can put my email on the bottom if you like.
Please do.
Okay. Now I know there's some other people still online. Does anybody else have a comment or a question or something else to add?
Yes, I'd be interested. I'm part of a care partner support group in Parkinson Canada. And if there was a way for this information or even to have a presentation there or to have a transcript of this presentation would be wonderful for the other participants. Because
I was planning to be in touch with Parkinson's Canada and ask if I could give a presentation, and then the pandemic happened. So I haven't done that, but I'll tell you this, when I went to England for my thesis defense, I brought I have like a spongy, a squishy of a red tulip in a pot that says Parkinson's Canada.
Oh.
And I brought it there with me and put it on the table, right?
yeah. No, listening to the comments and the participants, I thought, oh, it's like she's listened in to my husband and myself at home. It's my life.
Yeah, and I'm in the process of getting this written up and published. I just haven't done it yet. I've got to get onto it. I have reams and reams of data. Like I was drowning in the amount of material that people gave me. People were so generous.
Yeah. Well, I mean, it isn't a joyful path all the time to be on this journey, but hearing this and these comments, it's encouraging as a care partner to hear their story.
Very painful. My mother had Parkinson's, so I know from the family experience, but I know it's not easy for you.
Yeah, but there's encouragement through all of this in a weird way. Oh, thank you.
So, Margaret, we will have this recorded. And so anybody can access it as well, but it sounds as though you may want a more focused one with Rabbi Rena at some point to have a.
Yeah, sure, I'd be happy to do that.
That's great.
Yeah, and when I practiced this, it took me 45 minutes, but somehow it took me longer this time.
Yeah, I could pass your information to our group facilitator, or would that be fine?
Sure.
Okay, thank you.
Sure.
So does anyone else have any comments or anyone want to add anything else? Well, it was really a very powerful presentation, Rabbi.
Thank you.
Really wonderful. And
thank you, Esme.
So much, and we're really delighted that you had the chance to present this. And as I say, I think there's an excellent book there. I think there.
Well, I hope so. I keep talking about, I want to write a book about this, but the only book I have so far is my bound thesis.
Well, that's all right. It's just, but it seems, and just from the response in the audience today, you could see that those themes you brought up really resonated, and some very, very powerful quotes that you had for sure. This sort of the whole concept of disenfranchised grief, I thought was a beautiful job. Well, there's a comment in here saying, please start that book for Margaret. So, so that's great. All right, well, thank you, everyone. We really appreciate you coming today. If you're interested in spiritual care, we don't have it up yet, but I have done an interview with Rabbi Rena and about what is spiritual care. And we're going to put that on our Institute for Life Course and Aging YouTube channel as well. So there'll be this resource and another resource from Rabbi Rena. And by the way, there's a great promo video for Rabbi Rena that we discovered for University of Toronto for the certificate of death studies that had done a lovely profile of Rabbi Rena, which I don't know if you're still on, Susan, but can you just slip that into the chat if you can find it easily? So great. Thank you, everyone.
Thank you for the opportunity to present, and thank you, everybody, for your interest and whatever changes we can be aware of for people living with chronic illness will be very important.
Absolutely. Great. So thank you. And we will copy the chat. So
That would be great because I'd love to read all of this.
Okay, I will send it all to you right away in an email. Okay.
Thank you.
Right. Thank
Okay,
you.
have a good day, everybody.
Take care. Bye-bye.
Bye.